And good afternoon and welcome to everybody to the second in our series of 5 new webinars on the Millon Clinical Multi-Axial Inventory 4, the MCMI-IV. With this series, we are trying to get into a mode where we are getting more thoroughly into the application, into the process of giving feedback, and hopefully being able to really centralize the idea that the instrument is more than just a tool to be able to confirm or to rule out a diagnosis or to provide incremental validity, but something in which you have access to the theoretical underpinnings of it as well as the empirical backbone. You're able to use it in a much more powerful sort of a way. For those of you who joined us for the first in the series, that was much more purely oriented towards the theory and the undergirding constructs behind the MCMI-IV, that is Millon's evolutionary theory. We went into a great bit of depth on that, and part of what we'll be doing today will be oriented towards just kind of giving a preface on that, just a little bit of a review to be able to help you either remember from the first one or to give you just a little bit of an overview. And then we'll hopefully rather quickly start to move into some live examples, some ability to be able to utilize the theory more operationally. I'll try to demonstrate that to the best of my ability based on the experiences that I've had, as well as some of the written material that's come out over the past decade that has really tried to bring the instrument, both the MCMI-III as well as the MCMI-IV, more to life and more to the clinical spectrum. So just to go over a little bit of what we'll be doing today. Let's see if my controls will work for me. There we go. Like I had mentioned before, the first part of today's program is going to be a brief overview and kind of a refresher on the theory. So with hopefully striking the right amount of balance as to reminding people of what's in the theory, as well as keeping in mind that we want to get much more to the application, I'll be working our way through the basics of the theory and reminding you of some key points in terms of how that begins to apply. From there, we go into part 2, which is really the application of the theory, looking at this as a live assessment instrument, as well as something that can help you with feedback and develop intervention. This is an area that I really particularly enjoy, particularly in my own clinical work. And I've had a number of experiences throughout the years, the first of which actually being one that happened while I was postdoc in training quite a few years ago. I won't mumble quite as many years as it is. But going back some time, where I had to very quickly learn how to use theoretical elements to be able to kind of save an intervention that I was working with at the time. So from that point on, a big part of my study and a big part of the work that I've tried to do with the instrument and a big part of what we've tried to build into the MCMI-IV has really been geared more so than ever before, although this has always been a part of the MCMI, much more so to really dimensionalizing, really trying to bring out the more molecular characteristics of a human being so that you can utilize that language that the theory provides to help connect, to help the Therapeutic Alliance, to be able to work in a more collaborative sort of a way with the clients that you see. So throughout that part 2, you'll see that we're going to work through a review of the polarities and dimensions and how they inform the various scales and the elevations that you may see on an MCMI-IV. We'll work a bit with interpretation and we'll hopefully spend a good deal of time on how it is that we can really build a clinical alliance through feedback, through collaborative efforts, and through a means of working with people that helps really personalize the instrument as best as possible. With that in mind, let's take a quick look at the theory and remind you of some of the major elements, the major talking points, and things that really stand behind the methodology that we're going to be working with today. To begin with, I'd like to just remind everybody of why it is that the instrument does what it does in terms of being a true personality instrument. There are some comparisons that could be drawn. I oftentimes in live trainings use both the MCMI and other instruments. One great example of that would be the MMPI in its various forms. And I note how each fits part of the puzzle in terms of a clinical presentation. The MCMI being something that really has its lens focused on personality, whereas the MMPI focuses a bit more on collecting symptomology, but they each have their strength that way. The MCMIs being that you really begin to understand who the person is and what the personality means in the context of what they might be presenting, and the MMPI being with the kinds of presentations that you see, what can you possibly say about the person? So two different ways of looking at that. Of course, we'll be focusing today on the MCMI-IV and where it is that we place the idea of personality. And the figure that you see in front of you, just briefly, relates to a metaphor that we often draw between the medical model and the medical world and what it is that we focus on in psychology. And to begin with, we start with the innermost circle and say that in much older medical terms, in a bygone era of medicine, this is where we kind of focused our efforts, was that a person presented with a certain level of symptomology. We're talking about roughly the advent of modern medicine being the mid-1800s or so. And we conceptualized their diseases, their disorders, based on the cough, the fever, whatever it was that seemed to be the manifest symptomology. One of the examples of that, of course, being the idea that even something that might have more of an underlying cause, we described by its overt symptomology. Therefore, we had a term called consumption, and that was used to describe a major respiratory difficulty. As medicine moved on, it began to look at causal factors, and here we're looking at the outermost band on this figure, and that is what sorts of difficulties a person might encounter that might cause a medical concern. In the medical world, we were talking about infectious microbes or some kind of an invader of an otherwise healthy body. So therefore, what we used to describe as tuberculosis, once we started to really look more molecularly, what was consumption became tuberculosis. It was a reinvention of that. We've done quite a bit of that in psychology as well, understanding context, understanding the community that a person comes from, their particular background, particular factors that influence who it is that they are and what it is that they present with and how that might affect the innermost band here, that is their clinical presentation, their anxiety, their dysthymia, and so forth. What really became much more revolutionary, however, when we looked first at medicine and then at psychology, was the idea that there really was a moderator between the two. We really started to look at this much more seriously in the early 1980s or so, when we started to really understand and encounter the AIDS epidemic, understanding that HIV was a difficulty that could infect two people that seemed to be basically in the same level of health very differently. One might succumb rather rapidly. The other may go on and survive for quite some time with not nearly as many health complications. And the difference between the two really was the focus of the immune system. What the Millon inventories does, primarily, is to utilize the personality and understanding how a person's usual ways of being, usual ways of responding, reacting, emoting. Overall, how does that affect how it is that they might present? How is it that tends to be the moderator for the difficulties that they may experience in their lives? So this is really the core area of concern for the Millon instruments and the perspective that it takes in putting personality first and really focusing clearly on that. In today's presentation, we'll be talking almost exclusively about the personality constructs within the instrument. We may touch just a little bit on clinical symptomology and how that's affected. In our next series of webinars, the last 3 of the series, we're going to be going more into detail, focusing in on specific personalities, but then also saying, what is it that brings them in? It's not always that there's a personality complication or disorder. It's that they are experiencing an anxiety, an adjustment disorder, somatic symptom, other things that might be of clinical concern. So we'll be getting a lot more into that level of it in the next one. But for right now, we really want to do a deep dive into the role of personality itself and how to best get the most information possible out of the personality-oriented scales of the MCMI-IV. To do that, we turn attention to how it is that they're constructed. Here we're looking at Millon's evolutionary theory, and the figure in front of you being probably the best representation that we have of the core of the theory. Here what we're looking at are what constructs each of the MCMI scales, also what constructs each of the prototypes of the spectrum of personalities, according to Millon in various books that he's written over the past 40 or so years, and with particular emphasis on the most recent Disorders of Personality book. We have 3 major areas, 3 major domains that we look at in terms of personality, in terms of what it is that creates a person's basic motivations in life. And different configurations of this then begin to create the scales that we see on the MCMI-IV and inform us in terms of where they may run into difficulties of disbalance, where it is that they may find inner conflict, how it is that they best orient themselves to their world, and how it is that having a level of flexibility and adaptivity based on what I'm about to describe, how is it that that helps them or hinders them in terms of their overall mental health picture. So what we begin with are these 3 polarities, the first of which being the idea of existence, a major motivator in terms of how one organism, in this case we're talking about personalities, how it is that they gear into their world. We believe that all organisms and all personalities have a drive to exist, rather simple idea, oriented towards either trying to get as much out of life as possible or to try to protect oneself and just remain so that they remain alive without concern particularly for living life, just to be able to continue to exist. When we translate this to the idea of personality, we look at pleasure versus pain as a metaphor for this concept, the idea that somebody might really try to push forward and get as much out of life as possible or play it safe. Now, we know as professional psychologists and people who work with those who are presenting for mental health concerns that most people that we're going to encounter have some flexibility and adaptivity between the two. Organisms of different natures may not, but human beings do, even those that are more disordered in this sense. That somebody who remains entirely tight to the idea of pain or life-sustaining pain avoidance sorts of strategies in their life is going to run into difficulties of all sorts in terms of mental health concerns. Likewise, somebody who is entirely oriented towards life enhancement without concern for their personal safety, they too. And when I say personal safety, I'm speaking not only of physical safety, but also of mental health safety, of putting themselves out there, of undue vulnerability. Most people are able to strike a balance somewhere, maybe with their favorite place along that continuum, but for the most part, really being able to move between those 2 ends of the polarity effectively as life may call for it. Similarly, too, for the other 2 major areas, the second of which being adaptation, the idea of how it is a person adapts to their world. How do they interface with their environment? In this case, we're talking about either a passive orientation, where a person essentially finds a suitable enough environment, and if anything, changes the self in order to be able to best survive. Or an active orientation on the other end, modifying the environment, changing things so that it meets the needs of the individual. Once again, some balance is called for. Some ability to be able to modulate between those two extremes is very important for best mental health outcome. And different personalities are going to show different favoritism towards one side or the other. But again, the idea of flexibility, adaptivity is really best in this scenario. Similar to, and I think much more self-explanatory with the idea of replication, based on the evolutionary idea that no organism lives forever, and somehow we need to be able to nurture those like ourselves for ourselves to be able to continue on as our species. So we have self versus other. When we look at all of these in combination, we can begin to see how different combinations of these will develop and will build the different prototypes of the MCMI. Now, as we go on along here, I'm going to skip ahead because what I've basically done with this is missed the highlighted components. So as you can see, this is what we have just covered: existence, adaptation, and replication. And then I want to draw your attention to the bottom part. So we have these three different polarities, and then we have different kinds of dynamics and different kinds of orientations that go along with this. I've referred to, in this process, those who might have a very strong active orientation. Perhaps it's active orientation and a pain orientation. If you put those together, what you tend to see is someone who resembles something along the lines of the avoidant prototype, actively scanning their environment to be able to change over, to be able to withdraw effectively, to be able to protect oneself against all kinds of psychological threats, mainly coming from other people. If you were to take that same pain orientation and instead of having that actively withdrawing, actively making sure that they're okay sort of an orientation, and instead see somebody who has a passive orientation, that passive pain kind of orientation creates a different sort of prototype. In this case would be the melancholic, the kind of individual who tends to withdraw more passively, who tends to accept that life is going to be very difficult, that the environment is filled with all kinds of vulnerabilities, and essentially gives up or gives in to the idea that I have to accept the pain in order to be able to just make it through. Very different orientations. From there, I'd like to turn our attention over to the other side of this grouping over here. On the right-hand side, we have the polarity dynamics. Just taking into account that last example of the avoidant versus the melancholic, and understanding that in the MCMI, we're not going to usually have just one elevation, but we're going to have multiple elevations. And rather than listing a series of personality disorders, which the DSM tends to encourage us to do, what we do instead here is to look at how it is that if we had that combination, how that combination might blend together. So in this case, we would look first at, if we had one elevation, we would consider it to be unaffected. But if we had someone who elevated both 2A and 2B, that is the melancholic and the avoidant, we might then have a conflicted kind of a orientation there, such that a person doesn't really have a clear sense that they might be better off just giving in or better off protecting, and that can create other kinds of difficulties. We'll talk more about that as we go along. There are quite a number of other possibilities that happen both within each of the personality prototypes as well as when you combine them. And we'll be talking about both of those as we go on today. So, where we'll go from here in just a moment while I catch up on my guide here. I want to move our attention from the more theoretical and begin to look at how it is that this manifests itself in terms of the terminology that's on the MCMI, as well as how it is that we begin to measure each of these elements. One thing that I'd like to bring up here, and I'll be relating it much more directly to the MCMI in a moment, is that we really want to emphasize the idea that not all people who are subject to being assessed with the MCMI-IV need to have a personality disorder particularly. And that really the idea is that there is a continuum from those who have certain personality traits, characteristics, that are not necessarily in and of themselves problematic, but may present problems once in a while, through to those who have fairly well-defined personality characterology that is at a disordered level. So each personality prototype that we have within Millon's theory and that is then represented on the instrument might be described as a normal style that is the lower end of the spectrum, where we see certain kinds of behaviors and such that are somewhat predictable but are generally speaking adaptive. We have a level of abnormal traits or type, which is really where we would find the widest swath of individuals, not only who are presenting for clinical services, but I think a large part of the general population as well, where it's fairly well defined what sort of person they are, but we're not putting a diagnosis on that. We're not doing that in a way that suggests pathology outright. But we do know and we do understand that a lot of individuals will repeat their patterns. They will tend to run into the same sorts of difficulties on maybe something of a regular basis. Still, at this point, we consider these to be vulnerabilities, but not necessarily pathologies in and of themselves. And then at a higher level, we might characterize some people as having a personality disorder of their own. And as of right now, what we're still using in terms of the terminology is the DSM-5 terminology, which puts it into categories. That's its own debate in a lot of ways, but it's what we do tend to use right now. But in an effort to make it a little less categorical and a little bit more along the lines of dimensions, Dr. Millon, in his last theory book, spelled out a spectrum that represents these three different levels. And that is also represented on the MCMI as well. So if you look at this grouping in front of you right now, you'll see that within the columns you see the names of different disorders, and what we're using here are the abbreviated names that represent the various disorders, and the reason for that we'll get into briefly as well as those three different delineations: normal style, abnormal type, clinical disorder, such that we see the most common names for the most part on the right-hand column, those that we're familiar with: schizoid, avoidant, and so on. But really, each of those represents a continuum. From a lower base rate, and that is beginning at the base rate of 60, we look at somebody who scores at that level between 60 and 74 as apathetic. Between 75 and 84, we look at asocial, and then at the highest level there, we look at schizoid. Different ways of describing these different ranges of personality functioning. Similar for the avoidant, beginning with shy, and then moving on to reticent at the middle level, and then towards the end, then avoidant. An exception to that, then, is towards the bottom, where we see the three, what we consider to be structurally compromised personalities. That is, schizotypal, borderline, and paranoid. And you might notice that those common terms are actually in the middle here. These tend to be personality constructs that don't really have a particular normal adaptive style to them. but generally have a shift over so that we have what we usually consider the normal style, the beginnings of an abnormal type, a difficulty directly from that area, eccentric, unstable, and mistrustful. What we would consider to be personality disordered, but at a slightly more functional range than the very high clinical disorder, would be schizotypal, borderline, and paranoid. And then bringing in some of the older terminology that Dr. Millon utilized in the last book, describing those who are more decompensated, more so with much more difficulty functioning as schizophrenic personality, cyclophrenic personality, and paraphrenic personality. With all that in mind, we note that this, too, is also just the very beginnings of the overall picture of what we can do with personalities in terms of understanding what role they play in assessment and clinical challenges. The next part that we look at is the next level down in the theory. And continuing on a bit with the theory, we have these polarities, and we understand that these polarities really reflect the overall motivating aims of an individual, but we want to be able to get more specific, more molecular. So these then give rise to a series of domains that are very closely related to those that we consider to be our major schools of thought in psychology. So we break these down, first of all, into levels such as behavioral, phenomenologic, intrapsychic, and biophysical in this first column, and then further broken down to different functional and structural domains that represent behaviors, cognitive styles, different elements of intrapsychic sorts of structures, and so on, representing a lot of the different spectrum of the ways in which we look at personality and also aligned with different schools of thought in terms of intervention. One of the things that we're able to do with this system is that we use these as criteria to be able to also build the overall picture of what makes up one of the personalities. And because we have a chart such as the one that you see in front of you right now, we have a way of organizing all of these different principles. So along the left-hand column, you see the scale numbers of the disorders. And then across the top, you see columns that represent all of these different functional and structural domains. And an advantage to this system, as opposed to what's in the DSM, where you might have 5 out of the 9 criteria that makes up a criteria set for one of the diagnoses, where most of the criteria might be cognitive or a large percentage of it is interpersonal and there's a little bit behavioral. There is equal footing to all of these different areas across all of the different personality prototypes. This becomes important in the next section where we begin to combine different elements. If we have, for example, if we have an elevation of both the melancholic and the narcissistic scale, we may find that this person is not either a melancholic personality or a narcissistic personality in and of themselves, but much like red and yellow combined to make orange, we have something more specific that may have some of the emotional expression of a more melancholic person, but perhaps a cognitive style that's much more expansive, such as might be the case with narcissistic personality. And that combination really brings you much closer to the experience of the actual individual. So putting all this into place to be able to look at it as part of the instrument then, we looked at to see that those different polarities, we deduce and name a prototype from there. That is kind of a textbook model. Relatively rare that you'll see somebody that matches that exactly, but it's something to be compared to so that an individual can be compared to something that is developed for this particular theory and then represented by the 15 personality patterns of the MCMI. Putting all of those together then, we begin to look to see the combinations that make up the individual. When we begin to blend the prototypes, what we start to see then, let me see 1 second here. There we go. Okay. Most of the protocols that you're going to see are going to be those blendings. And the individual scales, again, I've alluded to this before, and I want you to kind of keep this idea in mind, is that those scales are analogous to the primary color wheel, except that the primary color wheel in this situation has 15 different colors. So you can imagine that there are many different combinations, some much more common than others. But when you have these combinations, you no longer have just the categorical model for something, but something that you can much more descriptively bring into the room with you. And that's where we're going to be going next. For the second part of what we're going to be working with today, I want to get much more into the application itself, look at scale elevations, and how it is that we begin to look at an active interpretation of an MCMI-IV. As we noted before, to begin with, to orient you to the scales themselves and what it is that we're looking at in terms of different anchor types, we have these interpretive benchmarks that match with what I was saying before. A normal style being at a base rate on an MCMI-IV, beginning at a base rate of 60 and going to 74. The abnormal traits or type going from a 75 to an 84. And the clinical disorder range going from 85 and above. So we're approaching a fresh MCMI that has just been given to an individual, and we have looked at what sorts of information is going to be on there. And I want to give you an idea, just a sequence that I use, which I'll just touch on the sequence for a moment. Again, we're going to be focusing mainly today on the personality-oriented area of that. But I want to mention and go through for you rather quickly the different sections of the MCMI-IV and why it is that we use the sequence that we do. To begin with, we look at the validity section to understand whether or not we have, first of all, a valid profile, and also to get a sense for ourselves, what sort of an approach did this person take? These are inclusive of the modifying indices scales, scales X, Y, and Z, disclosure, desirability, and debasement to get an idea, did this person give us enough information? Are they trying to paint a more positive, favorable image? Are they painting themselves as more pathological, and so on? Having a sense of that, then we go on to the noteworthy items to check to see if we have any specific differential diagnoses, or are there any red flags which would disrupt our normal interpretation and perhaps move us into something of a more tertiary intervention. From that point, we then move into the severe personality scales. That is the schizotypal, borderline, and paranoid scales of the personality section. Why is it that we do that? I'll go into a bit more detail on the next slide, but in short, mainly because we want to see the structural cohesion of the personality. We want to see if there's any elevations here, even if they are secondary to other elevations. That being the case that they may colorize what you see in terms of the overall profile. So if a person is presenting with an elevation on, say, the narcissistic scale, but also the paranoid scale is moderately elevated, that has a specific meaning to it in the colorization, that should be really primary, that we understand that there is more of a personality difficulty than what we would otherwise perhaps see if there wasn't that elevation in that section. We then move on to clinical personality, which is scales 1 through 8B, to get the general description of the individual, to understand those motivating aims. And then we move into the facet scales to try to break that down a bit further into the more molecular components of personality. Similar to this, but outside of the bounds of what we'll be talking about today, is the next section, which are the severe syndromes and the clinical syndromes. That is everything from major depression to more persistent depression, anxiety, bipolar spectrum, substance use, and so on. Using a lot of the same idea that we begin with the more severe syndromes, such as major depression, and we see how that might influence the course of the other clinical syndromes in much the same way as we did with the personality. For the rest of the time that we'll be speaking today, we'll be talking just about the personality sections, and I'll take you through a little bit of that in more detail of what we just spoke about, those three middle components. We begin with the personality interpretation with those severe scales, and we're looking to see what might be the case. If any of these, as the highest elevation, we might be considering that as a primary diagnosis. In most of the protocols that you're going to see these as either matching closely with some of the other scales or as secondary to some of the other scales, such that we look at the schizophrenic scale. We have the representation of that, the schizotypal scale. We see that representation of the different polarities, and we have this figure right here. We have what's called the wavering. That is, that these become very ill-defined. When I was mentioning before the mix of a 2A and 2B, a avoidant and melancholic, and that conflict that may come up between whether the person wants to defend themselves from a psychological perspective or just kind of give up and give in, that may create sort of a schism from reality and begin to show certain kinds of characteristics that are more typical of the schizotypal character. However, really it's better described, let's say that this is at a 60 and the others are more in the 70s to 80s range. You're still really describing the difficulty based on that particular conflict of whether I want to engage in keeping myself safe or whether I want to try to just kind of give up. In the others, the borderline, on the upper right-hand side, we see that this has to do with a conflict that occurs between all of the different polarities, such that it's very difficult for this person to really be able to do anything beyond create sort of black and white solutions to things and be able to look at something as either one or the other. That might occur, for example, with somebody who shows more of a histrionic or perhaps a turbulent or negativistic kind of a presentation where the conflicts have become much more abundant and you begin to see that difficulty with the personality. Similarly for the paraphrenic, which is the paranoid personality, here we see an immobility of the polarities, such that these folks tend to get much more rigid, much more tight in terms of how it is that they motivate themselves, such that it's very difficult to get that kind of flexibility that you might want in an intervention. With this in mind, with getting sort of a sense of if any of these are elevated at all above a base rate of 60, and whether or not they are the primary elevation, even if they're secondary, we get a sense of how it might colorize what comes next. That is, we begin to look at the co-elevations of the general clinical personality scales. Here I've brought up that same example as I've talked about before, the avoidant and melancholic. Particularly here we're looking at that motivational component of an active pain orientation with the avoidant, a passive pain motivation with the melancholic. And if this was co-elevated with a schizotypal elevation, and let's just say for this example that the elevation for the schizotypal is somewhere in the 60s, the other two are much higher, we tend to see that the person might become more distracted, more confused, tend to resort to thinking that's not directly related to the reality that's all around them, but really responding more to their own internal stimulus. And you get a better sense of what's making up that kind of a difficulty that that person might be experiencing. The next component that we would look at would be the facet scales. We would do that after we have a fairly good sense of the primary personality scales. And we look to see for this what kind of specific domains might be more present and might be more troubling. First, looking at the graph at the top, which represents the highest three elevations where the base rate for the main personality scale that it's related to, in this case, is the borderline, negativistic, or antisocial, in this particular example, where they were over a base rate of 60. And then we would look to see what's most prominent there. It's also sometimes helpful to look at the bottom section as well, which is the full listing of all of the facet scales, to see if we have any particular outliers that might be highly relevant to the kinds of questions that we have about the person. So that's the general interpretive sequence of the MCMI-IV, what's suggested in terms of how to go about approaching the personality characteristics. Now let's put this a little bit more into action. What we want to try to do from here is to take that rather abstract information and bring it into the experience of the person. So what we'll be talking about now is taking some of that theoretical language that I was just describing and bringing it into, or translating it as best as possible into language that's effective for the feedback that you might give somebody, that's effective for your understanding in terms of interpretation, and going that extra mile in terms of being able to help the person relate to what it is. I'll also be speaking about two different general methodologies, one of which being kind of the traditional stance that we tend to take as assessors in psychology, and that is sort of that we have this expertise in testing and assessment, and we're relaying information more directly to them, versus a more collaborative approach. And that approach is one that I've adopted a lot more, particularly over the last decade or so, where we approach it more from the standpoint of, I have expertise in this test, but you are the expert on you. And we want to put our minds together to say that this is how you responded. It's similar to how people in a normative group have responded. What might this mean for you? Giving them a bit more say in terms of working with the overall interpretation, and a method for doing that with this theoretical language that we have within this test. To demonstrate this, I've chosen an elevation that doesn't often show up only directly on the MCMI-IV. I've seen it more commonly when I've given an MCMI alongside of a Rorschach, but I have seen it on the MCMI-IV alone, and that is a co-elevation of narcissistic scale and the avoidance scale. So just in general, we wouldn't think about this as a possible co-elevation, but there are definitely possibilities. I bring this up particularly because of the differences, because it really kind of shows how it is that two very different personalities might commingle, might coexist, and create an entirely different sort of a presentation that you might not necessarily expect. So what are the different components of this? To begin with, we look at individual scale elevations. How will we break this down and begin to communicate this? We begin by looking at the motivating aims to try to develop a facility for descriptive language, rather than using the diagnostic categories from the outset saying, here's the avoidance scale, here's the narcissistic scale. We try to relate the observations that we might have about the person and then the observations that we have about the scales, and help them for more traditional verbiage. We might say, if this scale said everything about you, it doesn't say everything about you, but if it did, it might say so on and so forth, what that would be. A more collaborative approach might be, here are some observations about people who elevate the scale. Those who elevate scale 2A tend to be people who really spend a lot of their energy trying to remain safe. Is that something that you relate to? And so on and so forth like that. So what are some of the cues for this? If you were to take, first of all, the avoidant, what outlined here first are the motivating aims, as well as the personologic domains. And I've highlighted those that are Grossman facet scales, but from the theory, this is the entire set of personologic domains that go along with the avoidant personality pattern. This person will not necessarily reflect all of these, and as a matter of fact, in most cases will not, because there really is a co-elevation as well as different kinds of emphases across one versus another. So we're looking at those cues like I sort of brought before. That one of the more obvious ones, this person may really expend a lot of energy trying to be safe, but maybe not quite as obvious using those that are not as highlighted, pleasure and passive, and say, it must be really difficult to shut off. I would imagine it would be very hard to, in our terms, activate the parasympathetic nervous system. What you might say to them is just kind of get your own rest and relaxation. And then you might begin to look at some of the language that would be associated with the domains. Must be hard to really I would imagine that it would be hard to concentrate on various things. What do you do to spend your time? I mean, and you might elicit from them that they don't spend a whole lot of time really dealing with real world things, but they stay within their head, a fantasy dynamic, and so on and so forth. Outside of the bounds of even those that are directly within the Grossman facet scale, you may find that some of those are in and of themselves fairly highlighted here. Similar sort of strategy for the narcissistic. You would take that scale by itself and say, if this were everything about you, or you would say people who score high on this scale tend to be such and such. In this case, cues such as, it kind of seems like people who score high here believe that the world really will be there for them, that they don't really have to change too much about their world in order to have the good things that are coming to them. One of the things that I often note about those who score high here has to do with the fact that this is rather average, giving rise to sort of that insouciant mood that is often seen, that although there really may be some true concerns and true anxieties underneath, what they present at the surface is really kind of insouciant. It's kind of devil-may-care. So on and so forth. You're collecting information and you're looking to begin to define these things in a more descriptive way and sharing that with the person in whatever your best style is that way. Moving on from there, we then move to the dynamic interpretation. That is, now we've looked at the individual scales, we want to look at scale co-elevations and dynamics between the polarities and the domains. So we might see where two different personalities align or where they might conflict. Once in a while they might complement, and that might bring up a different sort of a dynamic as well. And you're going to look at the patterns among the facet scales as well. Sometimes you'll see that one domain is much stronger than another. Other times you might find that there's an unusual combination that creates something else in that same sort of color wheel idea. So here we would see that one of the main conflicts that we would see here is one is passive, one is active. We notice that there's sort of the insouciance that we might see with the narcissistic characteristics, but really what might be underlying that could be a very, very strong pain orientation. And this, in that case, might be more of a defense. We would also start to look not only at those domains that are within the facet scales, but those that might be important outside of there as well. You can see with the facet scales that sometimes there is a facet scale for both elevations, like both the avoidant and the narcissistic have an interpersonal conduct facet scale, but not all do. Sometimes you'll see that those tend to combine. If you put those together, that would mean something different as well. Finally, towards the end of this overall assessment and this ability to be able to get to this more molecular level, we would start to get more specific with the domains. and begin to note not only how they coalesce using the facet scales as well as using the rest of that chart in the related domains, also to begin to suggest therapeutic goals, to be able to say that this particular quality seems to be of a major concern to you, and perhaps explain to them how the nature of that particular quality, whether that be something in the cognitive domain or something in the interpersonal domain, might be best addressed by therapies that match that, matching the therapy to the person rather than matching the therapy to the clinician, which is what we too often do. So examples of this. These are some new charts. Some of you have seen some of my prior webinars and might have heard Dr. Millon over time, have seen this sort of quasi-Venn diagram before of all the different personality prototypes. This is a personality subtype. What I've done here is I've looked at this and used the relative size of the bubble that you see there to represent roughly, in one example or another example, how prominent a particular quality might be. Sometimes the most prominent qualities are not those that are covered by the facet scales. Case in point being, for this one, just this hypothetical example, this is example one, we'll show a different one momentarily, the haughty expressive emotion, that sort of behavior that's rather haughty. It's not covered by a facet scale, but you can see in this presentation, it's rather large. There's not a whole lot in terms of mood temperament that would be described as anguished. That's rather different. Those that are shaded here are covered by facet scales, and you can see that with this one, although there's sort of this devil-may-care, haughty, expressive emotion kind of a quality, there's really kind of some troublesome early objects there. That might be something that you would go after. Also, you notice that I've used different colors to represent in blue here the scale 5 and in red the scale 2A. But putting them together and making them purple, what if you found that you had a Grossman facet scale that elevated both aversive interpersonal conduct and exploitive interpersonal conduct? That could mean something rather specific. Slightly different example. Same general primary elevation. They might be a little bit different in terms of exactly how they're situated, but let's say that these are the two highest elevations again, at 2A5, and here's a very different sort of a presentation where you really do see much more of the avoidant quality at the outset, but you almost see this sort of awkward, admirable, but both admirable and alienated kind of self-image in terms of how they refer to themselves, in terms of how they try to make it so that everything is kind of okay, and in fact, they even overblow that so that it seems to be something that is a bit more contrived, a bit more just made up from what might seem to be nowhere. And you get the sense that although they're kind of trying to present like there's something special and even unrealistically so, there's really a lot more trouble that lurks underneath in a very different sort of a way than the first example. Using all of this information, and I know it's a lot to pack into an hour and a lot to really kind of absorb from that, you're able to get to a lot of dynamics that you wouldn't otherwise get if you took more of a general diagnostic or a kind of a categorical approach that's suggested by the DSM. And that concludes the major part of our presentation for today. What I'd like to do now is to turn it over to Dr. Gloria McCoo, who will field some of the questions that may have come in during the time that we were speaking here. Dr. McCoo.
Okay. Thank you so much, Dr. Grossman. One question that's coming in, and if you have questions, if you'd like to type them into the chat box, and we'll post them to Dr. Grossman. But one question, Dr. Grossman, can you address validity issues, specifically the positive impression management and how to detect that response style?
Okay. That is handled by something that was outside of the presentation today, but that has to do with the modifying indices that I referred to. That is 3 scales primarily: disclosure, desirability, and debasement, along with some validity indicators as to whether a person might have been random responding or if they were getting inconsistent sorts of responses. Primarily with positive or negative impression management, we have the Y and the Z scale. That is desirability, trying to paint a more favorable image, debasement being one that creates a disfavorable image. Those scales in and of themselves don't typically affect validity per se, but they may affect the way that you read some of the more substantive scales, and in some cases when you have that in combination with certain kinds of results, may create an automatic modification of the scores. It's usually either 5 or 10 points. It's not usually that's raw score points. So it doesn't amount to a very large change, but it can make the difference if you're looking at somebody who is really trying to be as positive as possible and may bring up some changes, or negative as possible on either the Y or the Z.
Okay, thank you. What recommendations would you have for books that could facilitate the interpretation of the MCMI-IV?
The primary book right now that speaks most directly to this is one that was completed by myself and a colleague, Dr. Blaise Mengeles, as part of the Wiley series on essentials of personality, or essentials of assessment overall. That is the essentials of MCMI-IV assessment. As part of that much bigger series. I see a question here that you've seen books like this for MMPI but not for Millon. We actually have in the planning stages, it's probably some time off, a book that is based on these kinds of interpretations, similar to one that was done for the MMPI by Steve Finn, that is oriented towards using the MCMI, in this case, as a clinical tool itself. Not sure exactly when that might get into the docket or exactly what the title will be, but that is one that's in the planning. Right now, the main one would be the MCMI-IV assessment.
Okay, essentials of MCMI-IV assessment. Thank you. Okay, I think that, those are all the questions we have so far. We've included a few references for you toward the end, and also we'd like to remind you of webinars 3 and 4 that are upcoming in November. November 1 will be focusing on the narcissistic and antisocial spectra, and November 28th looking at histrionic and turbulent. We want to thank everybody for joining us today, and we hope you'll be able to join us in November for those upcoming webinars, or if you can't then, you can join us in the future for some of our other webinars. Thanks, everybody.
Thank you.